Welcome. This webinar series, Designing for Behavior Change, a human-centered approach to research and intervention, is brought to you by the Human-Centered Design Task Force of the American Heart Association's Healthcare by Food initiative. This series is part of the initiative's cooperative studies model, designed to foster shared learning and innovation. This is session 2 of our 4-part series, designed to equip you with human-centered design tools and mindsets to enhance how you approach your research. If you're looking for more context on the series and its overarching goals, we encourage you to watch session 1, where we provide a high-level overview and foundation for what's to come across the series. It is important and necessary to start with this disclaimer. Statements, opinions, and study results presented in this presentation may not reflect policy or science position of the American Heart Association, unless otherwise noted. Now let's get to it. In today's session 2, we will be focused on applying journey mapping to reframe the concept of food as medicine. Our goal for this session is to use journey mapping to better understand and reframe food as medicine through a human-centered design lens, one that prioritizes user needs, behaviors, and lived experience. By the end of this session, you'll be able to 1. Understand and apply the journey mapping framework, one of the foundational tools of human-centered design, to analyze the user experience. 2. Reframe the food as medicine journey by focusing on what users, individuals actually experience and what they need at each and every stage. And 3, finally, integrate these insights into your own research, using the journey to inform your strategy, planning, and approach in a meaningful way. Let's dive in and explore how journey mapping can bring greater clarity, empathy, and impact to the way we design and study food as medicine interventions. In thinking of food as medicine, we've often conceptualized it by the relationships between healthcare, food, and food as medicine, with the idea that food as medicine sits at the intersection of the healthcare sector and the broader food and health landscapes. In the Health Affairs article, What is Food is Medicine Really? Policy Considerations on the Road to Healthcare Coverage, this Venn diagram, shown here, is used to conceptualize the relationship between food is medicine as a healthcare intervention with food and nutrition assistance programs, as well as population-level initiatives. While such graphics and ideas are helpful for illustrating food as medicine positioning relative to other programs and sectors, today we're going to dig deeper, exploring what these ideas actually mean in terms of the individual's lived experience with food as medicine throughout their journey. And we're going to do that leveraging a tool called journey mapping. A journey map is a visual or narrative representation of an individual's or user's end-to-end experience. It highlights their goals, actions, emotions, and interactions with a product, service, or system over time. In human-centered design, journey maps are a critical tool for ensuring that designs, whether they be interventions, programs, or research studies, are grounded in real human needs and lived experiences, leading to more empathetic and effective outcomes. And it's important to remember that the journey is not an isolated individual experience. It's shaped by the broader systems, structures, and contexts, the policies that an individual navigates, the social dynamics they face, and the resources they can or cannot access. In this way, also, a journey map can help us recognize these influences, enabling us to design with a deeper understanding of both the individual level lived experience and the larger system or context in which their journey unfolds. In this session, we'll apply journey mapping to understand the experience of individuals engaging with food as medicine, both in general and particularly in research studies and interventions. To start, we'll explore food as medicine by examining two adjacent journeys. First, that with traditional healthcare, and that with food. Let's start by considering the typical traditional healthcare journey with medication. It starts on the left-hand side with a clinician interaction. First, an individual patient goes to their healthcare provider, who determines that a medication is the best treatment option given this individual patient's presentation and situation. The provider then prescribes that medication. Now, there's a prescription from the provider, which the individual patient can then choose to fill or not fill. And we hope that they do get it filled. And once they choose to fill that prescription, their pharmacy prepares the prescription medication for them. Next, it is purchased, and this is usually where insurance or other types of payment mechanisms enter. Next, somehow the prescription gets to their home, which we call acquisition. There are different ways this can happen: delivery, perhaps a patient picks it up, or the patient may even have it mailed to them. Then we have put this line in the journey to represent the last mile, which we call from bottle to mouth in this case, because ultimately this medication prescribed, this regimen, only has an impact if it is consumed by the patient. And so the last mile of this journey is really from the prescription bottle into the patient's mouth, assuming that this is an oral medication, obviously. Well, we might consider the ultimate goal of this entire journey to be consumption of the medication. But it is not just consumption, but consumption is a means by which to improve the patient's health and health outcomes, which we've indicated as the last step to the far right-hand side. These health outcomes may take time, sometimes quite a long time, to show improvement.
Now let's shift to think about a traditional food journey, not necessarily considering food as medicine just yet. Instead, considering simply a traditional journey of food in an individual's everyday life. This traditional food journey starts with food and meal planning on the left-hand side. Maybe the individual is thinking to their week ahead, the family schedules, the lunches that need to be prepped. They're thinking, what's the family going to eat this week? What will the kids actually eat this week? Maybe they're also thinking, what's my budget? What's on special at the grocer this week? And then the selection of food. This may happen at a grocery store or a convenience store, or using the internet on their phone. It may be a very deliberate, intentional, and planned selection of food. Or it could be just kind of reactive or in the moment. It could be people purposefully navigating the grocery store, finding the items on their list. Or it could be individuals wandering without any list at all. Then that food is purchased. Somehow it makes it into the home, again called acquisition here. That could happen via delivery, it could happen by a curbside pickup, or it could happen by loading the groceries into the trunk and driving home. With many foods, particularly fresh food, there is some element of preparation necessary. Fresh produce needs to be chopped. A meal needs to be made. The food must be prepared in some way in order to be consumed. And lastly, at the far right-hand side is consumption. Note that in this traditional food journey, we've intentionally left off the final stage or goal of health outcomes, because that may not be the individual's goal at all. Their food choices and consumption may be tied to a wide range of personal motivations, such as cultural traditions, emotional comfort, convenience, cost, or simply what's available to them. Recognizing this helps us avoid imposing assumptions and instead center our work on the real priorities and lived experience of the people we're designing for. Now, looking at these two journeys side by side, we can start to imagine what a food is medicine journey might look like. We can see that there are shared or overlapping stages of these journeys: purchase, acquisition, and consumption. However, where the journey stages differ in location, in intention, in emotion, or necessary skill, these are the stages with even more questions for the food as medicine field to answer, as we seek to braid these two journeys together into one cohesive food as medicine journey. Fully merging these two journeys together, healthcare journey and the traditional food journey, we can propose a possible food is medicine journey, seen here. There are still many areas with unanswered questions, hence why we need many studies. Some open questions might include: is the clinician interaction where we imagine originating a food prescription? And is this where the food as medicine journey starts? What healthcare provider makes the most sense to do this? The physician? Probably not, as they are already overloaded and don't receive extensive training in nutrition. Once an individual gets this prescription, what does it look like to fill the prescription? Where do you take it to be filled? Who selects the food? Who prepares it? Purchase is another big element that we're thinking about in this initiative. Can we get insurers involved in the purchase of healthy foods as medicine? Next, the food comes into the home, acquisition. And after acquisition, we've put a line here in the journey again, representing last mile, which happens after the food comes into the home. A lot of times, and in many studies, we may consider only up to this point of the food entering the home. But the true last mile of food as medicine only starts here. The last mile, particularly for fresh foods, is from fridge to mouth. That is consumption. And this last mile can be long. We must now consider the intricacies of both preparation and consumption in the individual's household context, their routines, their daily life. It's not just the context, but also the associated implications for a food as medicine intervention. As mentioned before, with many foods, particularly fresh foods, some element of preparation is necessary. That could be washing and chopping, mixing and assembling, sautéing or baking. A meal needs to be constructed. The bottom line of the preparation stage is that most food must be prepared in some way to be consumed, even if it's just being reheated. And finally, there's consumption. Arguably the most difficult stage to measure directly in a food as medicine journey. Many studies will assume that if food enters the home, it's consumed as intended. However, program implementers on the ground often caution that this is not a safe assumption. Food may be eaten by other household members, like children or grandchildren, or in some cases, it may go to waste entirely. Now let's step back and consider the journey as a whole, keeping in mind its ultimate goal of improved health outcomes on the right-hand side. Starting there with the end in mind, the health outcomes we intend are possible if and only if the patient, not someone else in the household, only if the patient consumes the food as intended. Working backwards from there, from right to left, consumption of that food by the patient can only happen if the food is properly prepared. While medically tailored meals come ready to eat, most other interventions require varying ingredients not included in the box. Preparation, in turn, depends on the food being available in the home, which means it must have been acquired already, whether through pickup, delivery, or another method. Acquisition depends on payment, whether it's covered by a program or paid for by the patient themselves. Someone has to pay for the food. But even before food is acquired, it must be carefully selected and well selected. Successful selection often requires advanced planning. What meal will the individual be making? What other ingredients are needed to complete the meal? Are the right tools available in their kitchen? How much time does the individual have available to cook this week? Then, tracing all the way back to the very beginning of the journey is a clinical interaction where a provider prescribes food as medicine and the patient agrees to try it. This step relies on several assumptions: that the clinician understands and values nutrition and nutrition interventions, that the patient themselves believes food can help treat their condition, and that both parties are aware of accessible, appropriate programs. Thus, every stage of the journey is a critical step that must be traversed successfully in order to advance to the next stage. Each stage is dependent on the one prior. Our goal of improved health outcomes, therefore, depends not just on consumption, but on this entire journey being successfully executed by the individual and, in some cases, the healthcare provider as well. As we collectively seek to build evidence that healthy food can be used to treat, manage, and prevent diet-related diseases, we must consider that evidence against the framework of this journey. Our research must not only demonstrate improved health outcomes, but it must also advance our understanding across the many stages of this journey. This is an important reframe. This shifts our perspective to center the lived experience of individuals, reframing our goals and assumptions within that lived experience. Next, we will look at 2 research studies and their associated interventions, using them as examples of how this journey framework can serve as a powerful reframe. Both of these examples are early pilot studies funded by the American Heart Association's Healthcare by Food initiative. In each, we're going to highlight the individual intervention elements, noting how they each work in one or more stages of the food as medicine journey. It's important to note that these are not precise representations of these studies. We'll leave the detailed characterization to the research teams and their findings. However, we selected these 2 studies because they serve as strong archetypes. First is a pilot study consisting of 3 primary elements: medically tailored meals, or MTMs. The second element is the variations, where they explore feeding the household versus feeding individuals, noted as family meals for feeding the household. Third is delivery variation, which varies between an impersonal commercial shipping delivery and a consistent dedicated delivery driver that the individual may get to know over time and becomes a familiar face. As this illustration shows here, medically tailored meals address multiple stages of the journey, eliminating the need for food and meal planning, selection, purchase, acquisition, and largely eliminating preparation. Since the meals arrive ready to eat, the only remaining step may be minimal, such as reheating. The intervention of the delivery driver addresses acquisition stage. The distinction between family and individual meals focuses on the consumption stage of the journey, specifically whether providing meals for the entire household improves consumption by the targeted patient who we want to consume the food. These 3 elements align with the study's stated outcomes, which can also be mapped onto the journey framework to highlight the results of specific stages. For example, diet quality is connected to the selection of food. Food security is related to the food that is purchased for and available in the home. Meal sharing and meals consumed relates to consumption by the targeted patient. And loneliness is itself a health outcome that may be addressed via different delivery methods. It is an outcome of the delivery stage, yes, but also an important overarching health outcome. Again, it's important to note that these are not precise representations of these studies, but illustrative. Next, we look at a second pilot study. The goal of this study is to evaluate strategies to increase consumption of produce provided through a home delivery-based food prescription program. Mapping the three main interventions to the journey again, we see that first, produce boxes address the stages of food selection, purchase, and acquisition, though perhaps not completely, considering additional ingredients may be required to turn the fresh produce into consumable meals. In the case of this study, their second intervention, standard nutrition education, targets food and meal planning, food selection, and purchase. Lastly, the AI-based app can be used to generate food preparation ideas and increase engagement with delivered produce, therefore addressing preparation. Keep in mind that mapping interventions to specific journey stages may push you to be more precise, especially with broad interventions like standard nutrition education. Depending on the curriculum and focus of your educational intervention, this type of intervention could apply to multiple stages of the journey. But to generate strong, actionable science, it's essential that we clearly specify how the intervention works to advance food as medicine, what mechanisms it leverages, and at which points of the journey, so that implementation programs can effectively operationalize it on the other side. Mapping the study outcomes again here for the second pilot study, standard nutrition education aims to increase knowledge in specific journey steps. The AI-based app aims to improve cooking attitudes and the utilization of produce from the boxes. Lastly, overall fruit and vegetable consumption maps to the consumption stage and may benefit from all three interventions elements. These two example pilot studies illustrate how we can frame studies and interventions by the food as medicine journey. Likewise, we can use this journey to guide how we design our studies and interventions. Doing so helps us shift our perspective to center the lived experience of individuals. By looking at the full set of interventions within a study, we can better understand how a coordinated portfolio of interventions interact and complement one another. At a high level, American Heart Association's Healthcare by Food initiative is stitching together a large portfolio of research studies that collectively aim to advance evidence and insight across this entire journey. Now we're going to transition into our exercise, which is designed to give you and your study team a chance to engage directly with the food as medicine journey within the context of your own research, ideas, and challenges. In this session 2 exercise, we invite you to explore how the journey framework connects to your study. Specifically, you'll look at how elements of your intervention support behavior at each stage of the journey, and how you're defining and approaching outcomes in relation to those stages. To help guide your thinking, we've created an exercise worksheet that your team can work through together. I'll walk you through it briefly now before you get started. This is what the exercise worksheet looks like. We encourage you to download it, even print it out, and definitely engage with it as a team. In step 1, you'll list each of your intervention elements, 1 per field. If you need more space, feel free to use additional copies of this same worksheet. It's absolutely fine. Use as many as you need. Step 2 asks you to identify which stages of the journey each intervention element influences by marking the relevant stages. Finally, in step 3, you'll record the outcomes you plan to measure, aligning each one with the appropriate stage of the journey. If an outcome reflects the overall health goal, you can also note it in the final health outcome stage at the far right and in green. Now, before you dive in to complete your worksheet, I want to share a few insights we've gathered from working with dozens of study teams using this framework. And we hope that these insights will be useful to you as you work to complete the worksheet. To start, as we've worked with teams, we've noticed that intervention elements, in particular support components like nutrition education and counseling, are often described in broad terms. Taking the time to clearly define these elements, especially their intention, implementation, and how they align with and complement each other across the journey stages, can strengthen both the design and impact of your study. Useful specifications might include the goal of the intervention, that is the why. Second, implementation, or the how. The implementation details include things like modality, cadre of worker who will carry this out, and dosage. Is it a registered dietitian providing the nutritional counseling at an appointment once a month? Or is it a community health worker coming to the home weekly? Or perhaps it is an informational text message or an app that the individual engages with. These vehicles all have very different kinds of uptake with implications for engagement that we need to understand. Don't just say that you're doing an intervention. Tell us how you're going to do it. How are you carrying it out? Integration, or how all of your intervention elements work together in concert as a portfolio, is the last useful specification we might recommend. For example, how does your education intervention complement your produce box? Considering these two things together as opposed to siloed. For journey gaps, looking across your worksheet, once completed, what journey stages are not addressed in your study? What are the implications of that? For instance, we've noted that interactions with healthcare providers are a key part of the food as medicine journey, but they're not frequently explored in depth. Similarly, many stages rely on proxy measures such as engagement, ordering, delivery, or self-reporting, rather than a confirmation of actual food consumption, which is admittedly very difficult to do. However, there is an opportunity in this to more directly assess and not assume that final stretch of the last mile. Lastly, the human context. Some journey stages, like food preparation and consumption, are often underrepresented in research, particularly in terms of understanding what happens inside the home. These stages are deeply influential and deeply influenced by individual context. Exploring them more fully can offer powerful insights for both intervention design and research outcomes. Keep these insights from our own experience working with many study teams in mind as you approach completing your own worksheet, applying the food as medicine journey to your research study and ideas. As you complete this exercise with your team, we encourage you to use this framework not only to shape your current interventions, but also to inspire new complementary interventions and research opportunities. Now, thank you all for your engagement and thoughtful participation today. As we've seen, framing food as medicine by the individual or user journey offers a powerful framework for understanding how interventions work, not just in theory, but in the real lives of patients. By grounding our research and intervention design in this food as medicine journey, we move closer to building evidence that is practical, human-centered, and impactful. In our next session, session 3, we will be combining the COM-B behavior change model introduced in session 1 with the food as medicine journey that we've explored here today. Doing so will support us in creating nuanced behavior change strategies for implementation across the journey. We'll see you in the next session. Thank you.